Welcome to the November meeting of the Health Overview and Scrutiny Committee. We're still expecting more members, I believe, this evening. However, with me in the chamber, we have Councillor Adrian Mather, Councillor Jackie Rance, Councillor Michael Firmager and Councillor Sam Akhtar, and Councillor Barry Patman and Councillor Rachel Bishop-Firth. Do we have any apologies, Madeline?
Councillor Chen and Councillor Duran.
Thank you. Right, members, if you could look at the minutes of the previous meeting. In fact, we've got two meetings, the 21st of September's extraordinary meeting and the September meeting on the 29th. Does anyone have any comments or any corrections to make? Okay, I can't see any hands up. So would you like to put your hand up if you're in favour of these minutes? Okay, hands down. Anybody against these minutes or abstaining? Rachel?
I need to abstain because I wasn't at those meetings.
Thank you. Do we have any declarations of interest for the agenda tonight? No, thank you, members. Right, item 34, public question time. Madeline? No. 35, member question time. No. Okay, so we're moving to item 36, where we'll be receiving a verbal report from the Royal Berkshire NHS Foundation Trust. And tonight we're welcoming Raghuv Basin. I hope I've pronounced that right. Please correct me.
Yes, actually, Stephen Mannis, our chief exec, was also going to join at 7:30 because we thought we'd be on then. So if colleagues don't mind, if there's another item that can go ahead, if that allows Steve to join. Otherwise, I'm happy to continue with our I'm
afraid that's not possible.
Okay.
The other two items, knowing that they were later in the agenda, are not.
That's here. Absolutely fine. So my update is just going to be covering some of the key issues facing the trust at the moment. So I'm going to cover five areas in brief. The first is about the pressure we're facing in our emergency department, where we've seen a 20% increase in attendances compared to the same period in 1920. That's the second highest increase in the southeast region. Obviously, that's putting significant pressure upon our staff and upon the capacity of our emergency department, which was built for far fewer attendances than we're currently receiving. We are prioritising safety and quality at the moment, ensuring that all patients are seen within 15 minutes for initial assessment, and that we do not have any ambulance handover delays that prevent ambulances getting back on the road to go and treat and support other urgent and elderly patients. So this is a significant area of focus for the Trust at the moment, with the Trust executive supporting the frontline staff in the emergency department with improvement activity as well. We'll be launching this week a campaign around winter pressures, where we'll be focusing on three principal themes. One, for citizens to be prepared for winter, having a well-stocked medicine cabinet, support from families and friends. The second is knowing which service to choose, so not just turning up to the emergency department as a default, but working to utilise 111 services, pharmacists, and other alternatives in the local community. And the third is engaging with primary care in multiple different ways, looking both at face-to-face, but also online consultations, also the range of professionals that you now receive in primary care who provide care, not just GPs, but paramedics, physician associates, physiotherapists, and many others. The pressure we're facing in the emergency department is sort of compounded by the fact that we are focusing a lot on elective recovery at the moment. So that's patients waiting for outpatient appointments, operations, where there's a significant backlog due to COVID. Royal Berkshire is one of the few trusts in the country that maintained its referrals and kept open for all referrals throughout the period. But understandably, there were far fewer referrals than we might have expected, as patients did not go to their GPs, GPs did not onward refer. We're now trying to deliver elective activity over and above that, the level of activity we delivered in 1920. That is drawing in all of our staff, operational and clinical, into focusing on elective, whereas previously, in previous winters and under previous pressures, we might turn down some of the elective care seasonally to cope with the non-elective or emergency care. So that is two horses we're having to ride at the same time. Both key priorities for us, because we have a large number of patients who have been waiting too long for their treatment, and it's absolutely crucial we get to them as quickly as possible. As with non-elective care, we're focusing on safety and quality. We are focusing on ensuring that all patients with urgent needs, with cancer or urgent priority needs, get rapid access to treatment, and all patients who are on a waiting list are risk assessed to make sure that we are, constantly evaluating how we maximise our capacity and minimise harms that might come from waiting for treatment. The third area I'd talk about is the impact of COVID. So as people would have seen, case rates are rising. In the hospital, we're seeing a slight increase in cases. We have about 40 patients at any one time who have COVID in the hospital, with a small handful of those being on intensive care. But perhaps the greater impact of COVID at the moment is on our staff, where the resilience is challenging after going at this, as we all have, for well over 18 months now. Staff, particularly in respiratory wards, intensive care, have found it challenging to be able to take leave, and also the psychological impact of continuing to operate at such a high level throughout the pandemic is something we're focusing on in staff health and well-being and resilience, trying to support staff during what will be a challenging period ahead with winter. The other impact of COVID is the continued precautions we are taking to minimise risk of infection. So that's social distancing within our outpatient environments, within the hospital, continued mask wearing, continued tests before procedures. That does reduce the capacity we are able to provide, but obviously it's the right decision to make based on national guidance to minimise risk of further infection within the hospital. The fourth area I'd like to talk about is in spite of, or partly because of, all of these pressures, we're continuing to do our deep partnership working with colleagues across Berkshire West, within Woking, and also within our integrated care system, that's Buckinghamshire, Oxfordshire and Berkshire West, working with our local authorities, primary care colleagues, Berkshire Healthcare Foundation Trust and other acute providers to try and maximise our capacity and collaborate as far as possible. Some examples include Steve, as our chief exec, has visited a large number of primary care practices to understand how we can improve the interface between the Royal Berkshire and primary care, and developing a programme of forward work with primary care colleagues. We're working ever more closely with Berkshire Healthcare to deliver more joined up services. For example, our new long COVID clinic, which is one of the first to be set up in the country and is jointly provided across Royal Berkshire and Berkshire Healthcare Foundation Trust. And we're currently undertaking some work with partners in the integrated care partnership across Berkshire West, looking at our priorities for next year, with a commitment from all partners to deepen our partnership to make sure that we can really wrap services around the patients, users and communities we serve. And linked to that is a focus on health inequalities, which I know is a key priority within the Berkshire West and Woking health and wellbeing strategies. We are launching just this week a piece of work based on analysis we've done on patients who do not attend outpatient appointments, where there's a disproportionate number in the lowest income deciles, where we are reaching out through community engagement groups, targeted social media, to talk about the support we can provide to people to provide easier access to our outpatient appointments, to try and minimise the health inequalities we are facing in those areas. And we've developed 4 public health priorities that we're working with public health colleagues upon, looking at, for example, access to maternity services, the health and wellbeing of our staff, cardiovascular disease, and the example I've just given around people waiting for elective care. Finally, the fifth area I would highlight is the sort of continued focus on development and growing the organisation as an anchor institution in Berkshire. We've recently signed a new 5-year partnership with the University of Reading called the Health Innovation Partnership that brings together research, teaching, wider education, and making other links with the university, including taking up a building on the White Knight site in their Harborne building to relocate some of our pathology services. We continue to invest in our digital hospital. Look, we've recently launched a new internet, significantly improving the access to information for patients and clinicians. We are developing new patient portals, models of consent electronically for operations, and digital approaches to outpatient appointments. And obviously, we have our Building Berkshire Together programme focusing on the redevelopment of the hospital. Alison Foster has joined recently as the programme director. We continue to engage across the system and speaking to the Department of Health and Treasury to try and get a clearer sense of timescales for future business cases and when we might be able to make progress with some further estates work, building on the work that we've done in the past year around our emergency department and redevelopment on the site. I would flag there are 2 Building Berkshire Together engagement events in the coming weeks, one this Wednesday and one the subsequent Wednesday, which people will be able to find details of on our website. And I can provide details should the committee find it useful. So that's just a brief update on the key issues facing the trust at the moment and areas of focus. I'm very happy to take questions from members of the committee.
Thank you very much for that. I'm sure members have got a lot of questions for you. So perhaps, I know one of the things that people very much want to ask about is an update on the relocation redevelopment of the Royal Berkshire Hospital. Could you tell us something about that?
Of course. So that's the Building Berkshire Together programme. We have submitted an outline business case to the Department of Health, the new hospitals programme, to be considered. That has a range of options on it, including redevelopment of our current site and relocation to another site. At present, we do not have feedback from the Department of Health or the Treasury in terms of those options, the amount of funding they have provisionally allocated to us. So we continue to do engagement work with the local community and redevelopment work on the site where we think it is necessary. But we are approaching a time when we're going to need to understand whether we are still potentially looking at alternative sites for the hospital or going to focus on redevelopment on the Royal Berkshire site, given some of the urgent estate work that we need to do on the Royal Berkshire hospital site at the moment. So we've engaged with the national team a number of times. There was a visit by the national new hospitals team down to the hospital 2 weeks ago, and we're raising the issues through other channels. But we are not alone amongst hospitals who are in a new hospital programme in not having feedback from the national team, which I think may be tied to the current financial discussion with the Treasury and the conclusion of the spending review.
Okay, thank you for that update. Right, members, do you have any questions? Sam.
Thank you, Chair. You've noted here, Raghav, it says there are some backlogs currently which are providing a bit of an issue. Looking at the forecasts ahead, how long before these backlogs are sort of back to near normal levels?
Yeah, so those backlogs are particularly to do with elective care, and as people might be aware, this is a national issue for the NHS. So I say there's sort of 3 points I'd make. So one is we're currently delivering more elective care than we did in 1920. So we are eating into those backlogs. That has varied across different specialties. So some specialties had particular challenges going into COVID in terms of recruitment and retention that we're trying to work through and collaborate with other acute providers to deal with. Secondly, we do not yet feel that the level of referrals is that which we would expect. I was talking to our lead orthopaedic surgeon last week, and he has not seen the level of referrals for orthopaedics that you expect, say, this time 2 years ago. So we're still expecting more patients to come through, still returning to more normal life in terms of going to their GP if they've got issues. And those are maybe compounded by broader issues related to the pandemic, and I mentioned long COVID as well. And thirdly, we are expecting to see an increase in our waiting list and the number of long waiters, those over 52 weeks, over the coming months as we process people through. And then we'll expect to see that waiting list and the number of 52-week waiters decreasing over 22-23 and then beyond. At present, given the uncertainty about levels of referrals, I don't have a definitive date as to when we expect to be back to steady state, but we will be making marked strides over the rest of this financial year and into 22-23, and happy to come back to the committee once we've got greater clarity to update on that position.
Thanks, Raghav.
Adrian.
Thank you, Chair. I think it's clear with all these discussions that we've had over the last 18 months that staffing is a particular issue for everybody in general. But I actually wanted to ask some specific questions concerning the RBH. What sort of level of vacancies for staff do you have? And, how are you trying to retain staff and recruit new staff? And in terms of coverage for, those critical time periods during the 24/7 that you have to cover certain departments, are you still able to cover those critical departments 24/7?
Thanks for that. So I'll take those questions in reverse order. So yes, we are able to cover those critical departments 24/7. That does necessitate sometimes the use of quite high cost agency staff, but we're looking to reduce that through development of our own staff and permanent recruitment. The level of vacancies varies quite significantly across the trust, and that's largely mirrors national shortages. So, for example, there is a national shortage of radiographers to interpret and conduct scans at the moment. So in that example, we're working with the University of Reading to develop a training programme to effectively grow our own staff. And we're doing that in a range of different areas with the University of Reading and with other providers in the local area to try and create our own supply of staff, as well as those that are trained nationally. In terms of retention, there's a huge focus on the trust on retention at the moment. I think there's 3 or 4 strands I'd like to pull out from our retention approach. One is the significant amount of development and investment in staff that we give. So we are support and fund a range of training courses, opportunities for staff to take on management roles and clinical staff to develop their skills, which has been peer reviewed as one of the best programs in the local area. We're focusing quite a lot on well-being as well to make the trust a happy and positive place to work and significant investment. I think there's over 30 different models of well-being support that we provide to staff. Thirdly, we've invested in additional people management support to go in and support individual teams to address their recruitment and retention issues. We've recently run a successful maternity recruitment campaign focused on student nursing. And then fourthly, we continue to work with the national bodies and representatives of providers to try and represent the issues of our staff and make sure those are the top of the register for NHS England and government to make sure our staff have a voice about the recruitment and retention they face. But we are not facing shortages that affect our critical areas. We are continuing to invest and look at our own solutions to recruitment, retention and development of our own staff, from apprentices all the way through to consultants. But this is one of our biggest issues of focus as an executive and as a leadership team across the trust at the moment.
Thank you.
Okay, thank you. And welcome to the meeting, Councillor Maher. Would you like to ask your question?
Yeah, sorry about being a bit late. I was in another meeting. It's nice to see everybody not sitting behind glass. Just a couple of questions, really. One really relates to how the hospital, how does it communicate to the wider community that it serves, and how well do you think you do that? And the other thing, really, from the services that you give, not so much in terms of expansion or anything, what's your biggest worry in the next 3 to 5 years? And that could be in terms of the medical treatment that you're providing, or lack of staff, or even the financing side of things. What's your big worry? Thank you.
So I think on communications, we've got a big focus on this at the moment, particularly ensuring that we communicate with all groups across the populace we serve. So as I said, we recently relaunched our website. We're growing our presence on social media, engaging in more regular engagements through Health Watch, with patient groups as well. We're also reaching out to our voluntary and community services into different community groups. We built a lot of relationships through the vaccination campaign, which we continue and looking to build upon to make sure that particular groups who find it challenging to access our services are engaged. We have over 3,500 members of the trust who act as amplifiers for some of our messaging, and we're working with them to try and provide a slightly more 21st century approach to our communications using a range of different channels, making sure we don't exclude people by focusing on social media, but taking advantage of the full range of communication channels that we have, and we're looking to grow our membership. In terms of challenges, I think the point I've just talked about staff resilience, well-being, is probably our biggest challenge across the piece. I don't think it's focused on any one particular area. As I said, we have sufficient staff to meet all our critical areas, and we've recently conducted a safe staffing review which we discussed in the executive just today, which confirmed we have safe staffing going into and through the winter. But staff are fatigued. They're under a significant amount of pressure, and we need to continue to support them. And that's not just staff within the hospital, that's our colleagues in primary care, in community trusts, in local authorities. I think this is a shared problem for us all, how we maintain that resilience and well-being for what will be a period of significant pressure with COVID, the backlog I talked about before, and winter pressures.
Thank you.
Thank you. Michael.
Thank you, Chairman. Just a very quick question, really. I know during my visits to the hospital, car parking was always a bit of a lottery. If you could get in Craven Road, you were doing really well. I sometimes found the front of the hospital was probably better. But I'm just really wondering what steps the hospital is actually taking to make that easier, bearing in mind that Reading Borough Council do make it more it's impossible to park anywhere near the hospital. And in tandem to that, with the new hospital being proposed and built at some future date, I fully expect all this to be taken into account, at least I hope so. Thank you.
Yeah, so on the second point, car parking is absolutely, and travel and transport more broadly is absolutely vital to our development of the new hospital, and is something we are focusing upon as through all the option analysis. In terms of the current issues, we're looking at both expanding our parking footprint, particularly for staff, to reduce some of the pressures of a multi-storey car park. We've increased our presence at the Queen's Road car park. We're looking at alternative options around the site to expand parking. We've recently opened a cycle village as well, with spaces for over 100 bikes to try and encourage and support staff to transfer from cars into alternative modes of transport. And we're slowly eating away at some of the issues. We have a broader process involved with staff at the moment, looking at alternative staff options, because we know we need to find a resolution for this. I think parking pressures have reduced, but we have a programme which I actually lead, which looks at this on a weekly basis about the future model of parking that we need at the Royal Berkshire Hospital site, and we look forward to bring forward sustainable solutions in the spring following the conclusion of the winter pressures, to ensure that we are significantly reducing and mitigating all the pressures that people are currently facing.
Yeah, thank you. Perhaps just one further thing, just an idea with regard to some sort of shuttle bus. I don't know if that's something that could be factored in, but that's just a suggestion. So
No, absolutely. So we've invested in a shuttle bus that runs from the for staff, I would say, from the train station via Queen's Road to the hospital to try and encourage more staff to stop parking. And we're working closely with Reading Buses and others about trying to encourage more routes and bus routes to our locations. But it's something we continue to look at.
for that.
Thank you, Michael. Go to Rachel next.
Super, thank you very much. I mean, I've got another question about the staff numbers. Are there any broad trends of staff numbers up or down that you can see over time and that you may have forecast into the future? And I'm thinking there both relative to need and absolute numbers of staff that you're able to attract and retain. Thank you.
So our staffing numbers are generally going up, and we are recruiting more staff. We've recently had a number of consultant recruitments. These are replacement staff, which we filled successfully. Only a few years ago, those roles, such as in ear, nose, and throat, and gynecology and anaesthetics, were very challenging to fill. We place a lot of that down to the increased focus we've got on investment in staff, and also growing our reputation around research, links with academia, and some of the specialist services that we provide. And that focus is crucial to attracting more staff in what is a very competitive market to come and work at the Royal Berks. We know that we're in a position where we're good rated by CQC, relatively well thought of as an organisation. And so building upon that with our links with academia, with research, with universities is crucial to our future recruitment. We're also, I think one of the key things, it's quite hard to compare apples with pears. Sorry, like with like, because we're comparing apples with pears. So for example, we've introduced new staff groups such as physician associates, who are science graduates who provide medical care, but not at the level of consultants. We are one of the largest employers of physician associates in the country, and they are now undertaking, under supervision of consultants, a number of roles that were previously conducted by consultants to try and increase the breadth of what our staff do. So we are trying to grow those new staffing groups all of the time. So I wouldn't want to suggest that it's easy around recruitment and retention, and there are particular pinch points and pressures, but I think we are faring relatively well as an organisation. But the key for us is particular focus on retention and building those new staffing groups in particular.
That's great. Thanks very much.
Thanks, Rachel. Go to Barry next, please.
Thank you, Chairman. Yes, with regard to you mentioning about IT and so forth being used to try and improve the way that you communicate and so forth, I've noticed that certainly there's been quite an increase in that side of things, but how have you actually managed that? Have you taken on extra staff to look after all of the technical side of that for communicating, or are you taking the existing staff that were just writing letters and things like that, and training them, or how is that actually working to be effective? Because it worries me that there are likely to be a percentage of the population that haven't got IT and so forth, but might be missing out on that.
No, it's a really good question. So we've had a digital hospital program for since 2017, and that's effectively turned our hospital from a largely paper-based organisation into a very paper-light organisation. We were one of the few trusts that continued to invest in digital during the pandemic and introduce new digital elements such as in theatres and maternity. Crucial to that has been a staff training programme and staff retraining programme. So our administration teams who do a lot of the patient communications now largely work on digital means as opposed to paper means. Only a few years ago, we're able to use some of the data that we have collated to find tasks for artificial intelligence and robotic process automation, which means effectively the computer can do the work for us, freeing up the time of those staff to focus more on the quality side. So that's absolutely engaging with groups that use a suggested counsellor who might not be, might have more challenges in accessing the trust or might not be as familiar with digital to ensure that they get the same level of service. So it's very much adding to the skills and capabilities of existing staff using experts to do knowledge transfer. But we have a very clear focus, and through our patient leaders and patient champions, we test all of our digital programs with them before they are implemented and maintain clear lines of feedback from patients as to whether we're reaching everyone, because we don't want to exclude groups with new digital means.
Thank you.
Thanks, Barry. Paul, sorry, Adrian.
Thanks, Chair. It's good to hear that your RBH is addressing the backlog. Clearly, we have concerns about residents' access, especially when they've been waiting due to COVID reasons, etc. So, but yeah, it's good that you're addressing that. But I just wanted to check by the tone of your voice, you didn't seem too concerned by the backlog, even though you were stating you're likely to see further increases in waiting lists, for elective surgery, etc. So my question really around this topic is, normally you see some kind of constraint, whether it's operating theatre time, staff shifts, availability, or dare I say it, money. One of those things normally throttles back the number of operations that are performed. What is throttling back your organisation, or is there nothing throttling back your organisation at this time?
So it's a good question, and I think I suppose my tone was one of hopefully quiet reassurance rather than panic. But this is something that we focus on a daily basis, including on patient harm reviews, which happen twice a week to review patients on our waiting list. But I, along with colleagues, are constantly focusing on our waiting list and looking at how we can increase capacity to meet patients' needs. The largest constraint is around staff. And that's linked, partially linked with some of the other points I've made. So we are seeing staff are perhaps a bit less likely to take up some of the additional sessions that they might have done previously due to the fatigue that COVID has caused. So we're not able to increase, although we have increasing capacity more than we did at 1920, perhaps the levels that we might be able to based on just pure theatre capacity. I would also flag that the pressures coming on the front door mean that on the emergency pathway, there are staff who work on both pathways, particularly people like anaesthetists who are needed for trauma as well as elective care. So the draw on their time is quite significant where there are pinch points as well. But we are looking at every solution possible to increase capacity. We're working very closely with our independent sector hospitals to work with them to maximise capacity, to get patients seen as quickly as possible throughout all of this. So it's not it's something that the trust is relentlessly focused upon, but recognising that it's a significant challenge for us, which will continue over this year, next year, and beyond. And this is the same across the NHS at the moment due to the impact of COVID.
Another staff-related question. I guess you've got some staff who are refusing to be vaccinated. What is the trust going to do with those staff? Put them onto kind of back office duties, or what's the plan?
So we have amongst the highest levels of staff vaccination in the country, in fact, and we are having, there are some staff who are medically exempt for vaccination, and we have to take reasonable mitigations and have individual risk assessments about those staff, about what duties they can conduct and can't conduct. Where there are staff who have not yet been vaccinated, we are having individual conversations with them about the reasons for that, providing information, providing support. It is a very small number at the moment, but where those staff are making that choice, again, there'll be individual risk assessments about what duties they can conduct safely. Obviously, we wear quite high levels of personal protective equipment, but those are all signed off by our directors of nursing in the clinical areas to ensure that we minimise risk as possible, as much as possible. But as I said, we are at very, very high levels of staff vaccination, and actually our booster programme and flu vaccination programme is going well as well within the trust.
Thanks. And one further comment, really. It's very interesting you mentioned artificial intelligence. I listened to a very interesting example with Moorfields Eye Hospital, where retina scans were assessed by the artificial intelligence algorithm, which became actually better than the best consultants at identifying the potential outcome for the particular individual's eyes. So are you thinking of any specific applications around AI, or just in general?
So yes, so the Moorfields example is a really interesting one. They're sort of almost testing it on behalf of the country. We currently have artificial intelligence in place in a range of parts of the trust. I'll give you a couple of examples. So one in our stroke service with a company called Brainomics, which one of our brilliant consultants, Karuba, has developed, where AI is able to speed up diagnosis by 75%, and that's been clinically peer reviewed and is ensuring we get the right treatment to people as quickly as possible. We're also looking at AI to comb through some of our waiting lists and understand where there might be markers of patients who might have particular needs, so we can proactively reach out to them based on their GP records, proactively reach out to them and offer support based on the information we know about people. So it's both happening on the clinical side of things, so speeding up treatment. There's examples of use also with radiology as well, and trying to identify patterns, and also identifying patterns and areas on the operational side of things to try and improve our operational management and support our staff. But we are working really closely with the University of Reading on this, and particularly our informatics team are doing a lot of work. I've got joint PhD students, joint research, which is all governed within, as you'd expect, the clinical quality standards would need for research. But it is something we're proud of and want to continue to push.
Thank you. That's very encouraging. Thanks very much.
Right. I'd just like to ask slightly specifically about maternity services, because at our last meeting, when we heard from Health Watch, and they'd done a survey asking our residents here in Wokingham, I'm afraid maternity services had we had terrible feedback. The majority of people were not happy at all. I wondered if you could give us some insight into how you feel you're providing maternity services and what's being done to improve that.
Absolutely. So maternity, as with all trusts, is a sort of key area of focus, particularly after what was known as the Ockenden review recently. We know that we have work to do in maternity. We've had challenges with recruitment, retention, so 14% vacancies, a 10% turnover. We've just recruited 20 plus midwives. We've had a maternity summit with the executive and the maternity department in the past 6 weeks, which has agreed a series of actions to try and improve and support the workforce there and the patient experience we have. We're working with a series of patient leaders about trying to improve the services that our maternity department provides, and are expecting sort of independent verification of that in the coming months. So it is an area of focus, is something that comes to our board on a very regular basis. We have board members involved in the maternity improvement programme, and a big focus of our new chief nursing officer. But with the significant new recruitment and bolstering of the workforce, as well as some of the work we're doing around communications with patients and staff using our various social media channels, we are seeing improvements, but it's something that we have a relentless focus upon.
Thank you. We are going to be looking specifically at maternity services at a meeting in 22 of this committee.
Yeah, so we very happily, our director of midwifery, Jill Valentine, I'm sure will be very happy to attend with other colleagues to discuss the issues around maternity in more detail.
Thank you. Members, do we have any more issues that we'd like to raise? Any more questions this evening? Yeah, Adrian?
Yes, thank you, Chair. I'm in contact with some of the suppliers who do the voluntary pickups and drop-offs, and I believe one car parking space has been allocated over the last couple of years, I think. Do you know whether there's going to be any increased provision so that the volunteer organisations who pick up and drop off, I would say hundreds of people at RBH, are going to have a little easier access to RBH?
So we're actually in the coming weeks going to be setting up some dedicated pick up and drop off space for 30 minutes to address exactly that issue, both for our patients and staff. So we're doing some work at the moment to our car parking space, but I hope to introduce that before the end of the calendar year, and are working with voluntary services to make sure that our crucial voluntary drivers are aware of those changes and are able to utilise them, and constantly seeking feedback. If that change doesn't have the required impact, we will look to make further changes, because we realise what a vital service that these individuals provide for the organisation.
Thank you very much.
Well, thank you very much for joining us this evening, for all the information. You've answered our questions fully. If we've got any further questions, can we email them to you?
Absolutely, yeah, and thank you very much for your time. Really appreciate it. I need to go and run off and put some small people to bed, but I appreciate your time and very happy to follow anything up in detail.
Is there anything that you think we as councillors can be doing to assist the hospital, probably with communication with our residents?
So I think our winter campaign, which we've been working with a range of colleagues in developing, I might send through some details of that, which should be going live later this week, would be really helpful to try and amplify some of those messages, which is just about trying to make best use of the various services that the health and care system provide. So I'll make sure that information is sent over to you tomorrow with lots of materials that can be used in communications. That would be really useful, as well as your continued support for the trust as we look to redevelop our hospital to provide something fit for purpose.
Great, thank you very much.
And just a thanks to your officers as well, who work really constructively with us across all of the discharge pathways on integrated care partnership. So I know a couple on the line, but really appreciate their input.
Absolutely, we've got a fantastic team here in our adult services team. We're very proud of them, and thank you very much for appreciating that.
Brilliant.
And we'll let you enjoy your evening there.
Thank you so much.
Thank you.
Bye-bye.
Okay, members, our next item 37, we're looking at GP practice provision and GP services, and we're welcoming back Katie Summers. Katie was with us at the extraordinary meeting when we were looking at the COVID vaccination programme. Good evening, Katie.
Good evening, Councillor. Thank you very much for inviting me back again. I'm hoping that I'm going to do a fairly good job at providing you with a bit of an update about primary care access. But unfortunately, I'm going to have to start this meeting with a bit of an apology. Unfortunately, Dr. Debbie Milligan is unwell, and I was hoping she was going to join me in this conversation, purely because I think this conversation really needs to have a GP who can really present what is the current picture. Equally, I had asked Dr. Amit Sharma, who has been working very closely with Oakham Borough Council, to see if he could join. He wants to relay to you that actually he tried his best to come along tonight. However, he's dealing with some urgent issues in primary care and therefore wasn't able to join today. So I think it might be best if I just relay, if this is okay with you, Chair, the message that he wanted to just provide to this session before I go into the presentation. I have actually also in your pack, you've got a presentation here as well as a letter that had been written out to MPs. So from the local medical council by Dr. Richard Wood, which obviously would complement here what Dr. Amit Sharma is going to just relay to you. So basically he says he's basically sent me an email saying he's very busy tonight, so struggling to be available for the HOSC. On access, GPs are providing more appointments than ever, 30 to 40% up the demand versus from 2019. And issues are present with access and need folks to use online to free up phone lines, especially for those elderly and vulnerable. There's issues compounded at the moment in general practice by the lack of ambulance services, district nursing, and rapid response. And these all issues are preventing him from actually coming to this meeting today. So he apologises because of those issues. The big issue around resources, what he'd recommend, and this is okay, I start with what the actual members can do, is he really wants you all to promote the nhs.uk website, which should be the first line for majority of all people, which is really promoting community pharmacy as a point of contact. And he's doing a video on this tomorrow, which obviously he will sure be circulated with the comms colleagues here at Woking Borough Council, which I know he works very closely with. He also wants to relay to you that actually last night, that actually give you a real life example of some of the challenges that he's experiencing. So last night I couldn't get an ambulance to take a potentially septic 80-year-old man at his church, to have to drive him into the hospital to be assessed. And then today, a 20-year-old had the paramedic out twice in a week for a urinary tract infection and a headache, which he would deem to be completely inappropriate. So I think this is the issue. People are accessing the services in a very different way, but we need to be promoting it and actually ensuring that we're communicating, ensure that everybody has access to services that only the most vulnerable should be actually getting access to, especially to primary care. He says here we need to be educating particularly the actual age group of 20 to 40-year-olds, the use of services, so promoting it from the point of view of accessing online services, doing telephone triage, as well as also accessing the nhs.uk website for information. And also he says, finally, he wanted to raise you that there are lots of anxious parents and mental health across Woking at the moment. And obviously he wanted to say, what his final comment was, buckle up, tough winter ahead. We need to get the backing of our patients to help everybody going forward. And that was the message he really wanted to relay to you first of all. So I appreciate that's probably quite a hard ask that he's really put to you here, but I think I'll start off now with going through the presentation. Are you happy for me to share my screen? Would this be okay?
Yes, please do, Katie.
Hoping it's going on full screen. Hasn't yet. Okay. So to just correspond to what Dr. Amit Sharma had said here, we are definitely seeing a demand increasing following the ease of restrictions. And that is not only across the health services, but is incorporating also primary care. This is the list of the activities activities by PCN area. I haven't separated it out by Woking because I think it's fair to say you want to see it across the whole of Berkshire West. But you can see here what the activities are, and the real pressures from the GP's perspective are linked to the backlog in demand and extra secondary care work. And this corresponds to some of the work that Raghu had just presented to you about what's going on in the rural barks. They are seeing a huge amount of workload of follow-up problems, which primary care are having to re-refer now into the rural barks. So that is causing a waiting list issue. The chart below is the changes of our appointments activity over time, and this is corresponding from pre-pandemic episodes down to July 2021. So you can see here where there is naturally a definitely increase in the activities in primary care. The next table here looks at the changes of activity by age groups. So this is corresponding here, the percentage increase in consultations by PCNs from during July 19 to July 21. And the range is quite significant. So you've got some PCNs that have actually only seen about a 17% increase, whilst others, and notably you'll see here for Woking West PCN, they've seen a 155% increase in activities going forward. So the real pressures here in primary care are present really going forward. Face-to-face and telephone consultations have seen show a decline in these contacts through PCNs. And although the 5% increase in overall, so I think this is to do with the fact that actually we have seen that actually the whole point of primary care has really shifted, and that corresponds to the letter that Richard would have actually written. We're now seeing actually primary care is really moved into a much more of a telephone conversation mode, and this is also to support them from protecting their staff from potentially outbreaks, but also dealing with the massive burden that's actually upon them at the moment. So it's a key issue in the fact that now primary care is actually really seeing a difference in how they're working going forward. So the impact of current activity has also not reflected in the demand and activity. So online requests such as emails, practice websites, requests and text consultations have increased, which have been a really vital tool in communication and consulting patients. Although there is a national drive to map appointments of all types and provide and improve data is expected. So what we're saying here is the fact that generally in the past, pre-COVID-19, a lot of the public would have been just phoning up their practice in order to get an appointment. But during COVID, the whole system changed, and now what general practice and local public are trying to organise is a way that they first of all may want to use an online appointment system, first of all, which would be through the practice websites, but also doing a telephone triage before they actually visit the GP practice. Face-to-face consultations obviously at the moment take longer, and in the report from Richard you will see here that actually an average face-to-face consultation may have taken over 20 minutes, whilst a telephone consultation obviously takes a lot shorter, which means actually now there's more time for dealing with the most vulnerable, especially the elderly, in as a face-to-face appointment. Despite some patients returning to face-to-face consultation, the new flexible way of consultations has been much anticipated and take up by many, including those who prefer not to attend the surgery for work or health reasons, unless it's necessary for them to do so. And I would say that we're hearing at the moment from the point of general survey, we're seeing here that lots of people do appreciate the actual point of view of doing flexible approach, especially those working, but some people don't like it because they much prefer to have that face-to-face appointment. Housebound patients and their transport difficulties have more access than before, and you can see here from that report with regards to what Amit had said, he was able to go and visit the actual individual 80-year-old and actually sort that person out, which he may not have been able to do beforehand. And we'd like to see a continued mixed model going forward, with greater emphasis on offering face-to-face in response to patient preference as well as clinical need. The recovery plans is that we are going to be supporting a step down of the respiratory hub arrangements, with all patients now managed within practice. So the hub was expected to be closed in March, and what this is seeing now is that we are going to see much more suspected patients now being seen by practice. And so now the practices are now dealing not only with their normal routine, but also they're also seeing those people who are suspected of COVID. Hence reason why these people need to be seen by telephone rather than having an actual face-to-face appointment, because obviously there's infection control issues in place. Further work to embed new models of access in primary care and support patients to engage with these, being addressed through digital inclusion programs and communication campaigns, including introduction of digital champions to support all groups in accessing care. Now, this is a key thing. There's been some material that's recently been sent out by the CCG and has also been adopted by the council, which is giving a poster about ways that actually the public should be accessing primary care going forward. And obviously we have done some work of the planning for the next phase of COVID vaccination programme. The backlog of routine appointments is being addressed. And obviously at the moment, the key thing for primary care is they're focusing on to ensure chronic diseases are appropriately managed. So this is a key thing for them. Funding has been made available to increase GP capacity, and oximetry at home arrangements have also been supported. Now what that means is that now GPs have been given pulse oximeters, and anybody who has actually had suspected COVID, they can be given an actual pulse oximeter, and the GP is organising a daily call of those individuals in order to support their management as they come into, if they have actually COVID themselves. We also have a long COVID management plan, and equally they're supporting clinically extremely vulnerable people in their management. So actually there's a huge amount of work that the GPs are ensuring that they're doing to support catch up, especially of those most at risk and those in chronic diseases. And that goes with what I was saying earlier on. This is the key thing, is that GPs are really here to support the most vulnerable as well as the frail elderly, and they want to ensure that they give those individuals as many face-to-face appointments that they can give them as possible. However, obviously at the moment we need to ensure that the whole population is using the services appropriately. Improvement is seen in routine vaccinations and immunisation rates. And we're seeing this as part of the vaccination programme. We're doing a lot of work, as you'll know, about the vaccination programme itself at the moment. Wokingham is one of the top areas for vaccination, but it's fair to say there are still pockets within Wokingham that we know that are seldom heard groups that actually are still needing to be vaccinated on. So there's still a huge piece of work. And actually your practices in Wokingham are at the moment fully supportive of the vaccination programme. So they're dealing with not only that chronic disease management, but they're also there and delivering on the booster vaccination programme. Focus work is to support vulnerable people, as I was saying here, and obviously they're trying to address inequalities, especially in relation to things such as learning disability health checks and physical health checks, especially for the severe people with mental illness. The system-wide workshop was agreed in May, and there were some key things that came out from the actual actions that we needed to address primary care demands. So the key things here was the fact that we were going to be building intelligence about the activity in primary care, including predictive modelling. This is being worked up from the Bob Integrated Care System at the moment, and we're waiting for work to come out for that. But I'm pleased to say that when it comes out, I'm happy to come back and share that information as we go forward. 111 call handlers are now able to book directly into primary care, and actually most GP practices are freeing up appointment times to allow 111 to directly book into their practice when an individual 111 doctor has actually been assessed them as needing an actual on-the-day access for primary care. We're also supporting a standardised telephone message in general practice. We know that actually at the moment in Wokingham, there's very varied ways of the types of telephone messages that are left for for individual residents. So the CCG is organising a way that we can make sure there's a standardised telephone message and actually helping individual residents not have to wait so long before they get in contact with a receptionist. We're maximising GP call handling and workforce management capabilities. And what we're doing here is organising training with receptionists in order to ensure that our workflow management is better utilised. And with this is not just about allowing people to see a GP. A lot of the actual GP practices have now extended the roles, such as additional roles such as paramedics and pharmacists. And there's nothing to say that some individuals cannot be seen by those people. One big thing that has happened has been that we've now, as a CCG, commissioned 170 appointments per day across the actual CCG to increase capacity, and that ends in March 2022, it says here. However, today we were informed by NHS England there's a new fund known as the Winter Access Fund, which is also being worked out for Bob Integrated Care System. That accounts to £7.4 million. So generally here, I think that the Bob ICS will be working directly with our GP colleagues to ensure we have a really good system to allow as many people to have the opportunity to come in and be assessed in primary care. So that's building on the additional 170 appointments per day. You heard from Raghu, we're piloting how the rule barks might be able to book patients directly in for a GP appointment as well. So this is a key thing. It's being trialled at the moment. And actually it seems to be going quite well as is at the moment. And this is a really supportive thing because it's a way that the GPs are now able to work directly with the rule barks. It's building up the trust of the rule barks and GP colleagues to allow that direct booking between the ED department and also GP appointments. Practices now have a front door open, so patients can book in person. But as I was saying here, most practices are really pushing to have a telephone appointments, and that is the first point of contact going forward, which obviously might not necessarily be suitable for everybody, but it's a really important way that we can get people to have an immediate, within a couple of hours appointments with a GP, rather than having to wait maybe a couple of days before a GP could be seen. But these individuals who need to actually be seen, if they've had a telephone triage, will be seen on that same day. We've established a community pharmacy consultation service as an alternative to GP practices. And actually this is a key thing that we're working on at the moment. And also exploring an enhanced telephone system used in general practice. Some of the GP practice telephone systems are a bit out of date, I would fair to say. They're not cloud-based, and what we're trying to do here is make sure that we have as many lines open as possible, but also have information on the lines. We can actually direct people to the right services as is going forward. So that's a bit of a quick fire summary for you about the actual presentation I gave to you. You've then got a letter which is actually from Dr. Richard Wood, which is actually giving you some information from the LNC about what's actually happening in general practice. As he was saying here, the advantages of a hybrid model, which is actually obviously supporting both telephone and in some cases video calls, is here to improve access and safety in the context of massive demand. And as you can see here, there has been massive demands. Obviously, a face-to-face issues takes about 14 minutes to be seen, but actually if they've done it by a telephone consultation, they can normally see it with 8 minutes, and then they can free themselves up to actually see those people at most need on the same day through a face-to-face appointment, which is a really important thing going forward. So at this point, I'm happy to take any questions because I'm going to presume, Chair, that everybody's read the actual letter and also received the actual presentation. So I'm happy to receive any questions from the members here.
Thank you very much for that, Katie. I mean, you very much focused on the impact of COVID on the service that our residents here in Woking are receiving from their general practitioners. I think many of the councillors here will be aware of a patient survey, a recent nationwide GP practice survey looking at 2017 to 21, the key patient experiences, where, you know, I think it was fantastic that 5 of our surgeries are in the top 10%. We're delighted that our residents registered with those practices are getting such an excellent service. Yet 4 of our GP practices here in the borough were in the top, we're in the bottom 10%. So my question is, why are those 4 so poor when others are so good? And what are you doing to support those practices to ensure that every resident in our borough is getting the standard of service that they expect? Katie, I think you're on mute.
Apologies. Yes, I do recognise that this issue has been raised several times by members of Woking Borough Council, and obviously the CCG has responded on a number of concerns raised about the delivery of primary care services in general practice in Wokingham areas. And as you say, the recent patient survey is just, you saw here that actually that was 4 practices did, most of the practices did well, but 4 practices seem to be on the top, the bottom 10%. One thing I think that the survey did is only looked at one aspect, which was just literally on data and intelligence. And we want to look to get a clear understanding of the performances at those actual individual practices. Now, one thing that the launch is doing at the moment is there's a new system across the country called the GDPA, which is a general practice data audit. Now, that general practice data audit at the moment has shown to be not necessarily giving the right level of information. The national team are working on improving that actual reporting mechanism as it is at the moment. And we're hoping over the next couple of months, we'll have a better understanding to do a comparison of like for like between practices as it is at the moment. Obviously, the pandemic and the vaccination programme has placed immense pressure on primary care, which has previously not been experienced. And that said, there is a clear need for practices to continue to meet the needs of patients through a delivery of both responsive and planned services. And obviously, members of HOSC may be aware that NHS England has recently committed a winter access fund for integrated care systems. And this will be used to increase the number of appointments available to patients and improve access to services during that winter period. Now, with that piece, I think this key thing that the CCG will be doing is focusing on those practices where we've seen that there is a low patient survey report. So we will be working directly with those practices to ensure that we're listening to what the survey had said, but also responding to people like Healthwatch who have done recent reports on those individual practices and finding out what those individual issues are so we can make sure we target the work of that Winter Access Fund going forward. Planning is to provide tailored support to those individual practices. And we were working with Wokingham to develop, obviously, those plans and to support increasing appointments and also increasing access. The decisions will be made quite rapidly on how we're going to support those individual practices, and those will be done in the next 2 weeks. And obviously, we will provide an update on some of the interventions that will be delivered. So maybe what I can do is provide a report to HOSC. It might be a written report, or you might want to invite me back with another GP to give you an update about what's happening with regards to those 4 practices. Now, this will be part of an overarching approach to services through a busy winter period. So I think there's a lot of work that we will be doing to support those 4 practices as it is at the moment. But obviously, I'd want the HOSC members here to be aware that we're going to do some targeted work over the next 2 weeks as part of that Winter Access Fund to actually make sure we get a design plan that's fit for purpose based on the individual response from the actual practice survey, but also responding to some of your concerns that we've got obviously reported here, but also any concerns that Healthwatch have also put forward as well.
Thank you, Katie. I wasn't sure at first if you were disputing that the survey reflected the feelings. I mean, I know all councillors and our MPs are kept quite busy with our residents writing to us about their GP practices, and we have to explain that as councillors we don't have any influence. We can just make sure the CCG are aware of the levels of dissatisfaction. I just wanted to pick up about the out of hours GP services. So you're saying they are experiencing heightened patient contact. I just wanted to be clear about the funding. Is that good enough to maintain the level of activity? And, you know, are you attracting enough clinicians to service the demand? Because I just wasn't clear if the access figures included out of hours activity.
So out of hours activity is part of that big picture of that 7.4 million opportunity as such. And what we're trying to do is think about this as a total picture. So part of it is obviously within practice. Part of it will also be as part of that out of hours. Part of it also will be part of that 111 service as well. So the capacity question is, which I felt that you were asking, Chair, was about, do practices have enough opportunities, enough staff such going forward? This is an active conversation that is currently going forward. Obviously, GPs, a number of the GP practices have seen some of their GPs retire. We've organised a way of supporting returners of GPs during this crisis period. We've also supported a programme of retention as well, especially for those people who want to retire. We're also working with the individual GPs to ensure that we have locum cover, as much locum cover as possible to support the system as it is at the moment. On out of hours, what we're hearing is at the moment, the out of hours services, which is actually provided by Berkshire Healthcare Trust for a system called Westcall. The Westcall service, it is under immense pressure. They are, most of the actual Westcall GPs tend to be off-duty GPs across the Berkshire system, as well as some interim GPs as well. We're not seeing any forms of capacity issues regarding the Westcall system itself. However, it's fair to say that actually the GP practices are very, very concerned about the individual capacity against the individual demand. So if I compared it from last year or pre-pandemic, we are at a pressure point with retired GPs. Now we've had pandemic, we've got increasing demand, as well as a retiring GP community as well. So we need to ensure that we get new GPs coming into the system as clearly as possible. But at the moment, most GP practices are working on getting in extra support through interim capacity as possible.
Okay, thank you for that, Katie. Members, I'm sure you've all got lots of questions. Sam?
Thank you, Chair. Katie, linked into your last question, has the GP training programme continued during the pandemic, and are you hopeful that we will see an appropriate number of newly qualified GPs joining practices shortly?
Yeah, so the GP programme has continued during the pandemic. We're very fortunate in the fact that actually most of our GPs have got a training facilitators, so they are supporting trying to recruit people to come into the general practice as clearly as possible. We've also had a work programme of advanced practitioners, and a number of our GP practices have actually had advanced medical practitioners based now within their individual practices. So classic examples of that are through Brookside, and I also believe that Woking Medical Centre have also gone forward with an advanced medical practitioner. We are seeing that actually the number of people coming into general practice as a GP trainer has been maintained, and actually we're not seeing a drop off at the moment. What we are quite keen on doing is promoting the actual work of general practice and expanding that work. Now, I would say that the general practice and GPs are almost like a rare metal, they're a rare commodity. And I think this is where NHS England have now expanded the role of primary care workforce to not just being general practice, but actually bringing in paramedics, advanced nurse practitioners, pharmacists who could be part of a primary care medical team. And the best way to describe this is probably in the past you would have just been seen by a GP, but actually I think most general practices now are going with much more of that hybrid workforce model, whereby you might not necessarily seen by a GP, but if you have a pharmacy repeat issue query, you might be seen by one of the practices paramedics who will be able to undertake a medication review, give you a lot better advice about your medication needs, how you best to actually manage your day-to-day needs as part of your medication prescription, and you'll be seen by that paramedic. So they're expanding the types of workforce, which would be very similar to how it would be in an acute setting or a community setting. So not just being loaded by just one profession, being a doctor, but doing it through a much wider range of doctor, nurse, paramedic, pharmacist.
Thank you, Katie.
Okay, Tahir.
Thank you for your presentation. I've just got kind of a couple of points, observations really to some extent. I agree with the way the surgeries have kind of changed their approach, and you tend to see them over the internet and maybe even take photographs and put them up on the web and so forth. And that can really only work for people who have access to the internet and smartphones and the rest of it. One of the things that worries me is, and I don't know whether everybody uses that or whether it's just my surgery, and that's the e-consult. It seems to be an application that was developed with the doctors and not with the users in mind. It is very unfriendly, user-friendly for, especially, I like to think of myself as quite savvy with applications, but it really has lots of dead ends where it tells you where to go. And I've used it about 3-4 times, and on at least 3 occasions, I've had to then phone the surgeon saying, this is what I really want, and it's not giving me that at all. And it's just stopped it. So if that's doing that to me, to other people, it really isn't user friendly, to be honest. And the other thing really is, I know that a lot of people, because we are all humans, like a face-to-face consultation as much with the doctor or the nurses as they can. Are we going to get to a position again where, at least predominantly, we get back to face-to-face consultations, or is that really going to be at a certain level only, which is quite serious, or where they feel they need to see you personally, otherwise it's all phone calls or through e-consult? Thank you.
Thank you, Tamar. So I'll start with that last one. Generally, most GPs would, and I hope I can say this on behalf of GPs, they would love to go back to delivery of the face-to-face way that they were working pre-pandemic. That's their bread and butter. That's what they're used to at the moment. So I cannot, at the moment, I'd like to think and say to you that actually in next year that they would be moving to a greater work of face-to-face as at the moment, but they're trying to balance out the current demand that I showed. At the moment, that's got to be supported on a telephone way, and then helping them to decide which people that they need to have as a face-to-face via a telephone is the most appropriate way for them to deal with that. I appreciate that. I think that once we get over the pandemic, I think that's when they all be reviewed again, and whether or not they move from the hybrid or whether or not they they go back to a new version, which would be a modified face-to-face. We'll have to wait to see going forward, but at the moment it has to be that hybrid as it is at the moment. On the issue of e-consult, I'm a bit surprised actually you're having difficulties. And it's really good to hear that, and if you're raising that with the individual practice, which is really good to hear. eConsult is one of the providers of online solutions. Other GP practices use a system called Footfall as well. But most of these providers have all been assessed via NHS England as being an actual patient user-friendly application. They're all gone through a due diligence route as such as it is at the moment. And so I'm welcome, Tamar, if you speak with me directly, it might be the way that the individual practice has formulated the e-consult on for their practice, which is actually preventing you from actually having the best version of it. So it might be some form of configuration as it is at the moment. eConsult tends to be one of the main providers of online consultation services across the country, so it's used quite heavily, and so I'd like to make sure that you don't have those issues as it is at the moment. So maybe directly email me after this meeting and just tell me the name of the practice. I think I know which practice it is, but if we could speak offline, then I'm happy to try and sort that out for me.
Thank you very much. I will do.
Yeah.
Thank you, Tahir. Thanks, Katie. I'm going to Michael next and then Jackie.
Thank you, Chairman. I was going to ask a question, which you've kind of answered following the Chairman's question about the 4 surgeries, about improvement plans. So I look forward to receiving those and see what happens to that. My other points also got covered, actually just previously as well. You've covered it about face-to-face meetings. And I think we know from patients they want face-to-face meetings. They do not want hybrids or virtual or phone or anything like that. They just want to see a doctor or another medical practitioner or medical professional. But I mean, my great fear is that things will be misdiagnosed or won't be diagnosed, and people can unfortunately die because of this. And I'm just really wondering what sort of plan you've got to get back to face-to-face appointments, going back to pre-COVID levels, because I think that's what patients quite rightly demand, and that's what they expect. And I think it's their right to have that service as well, because they do pay into the NHS.
Okay, thank you, Michael. So yeah, as I was saying, I think this extra money that has been given to us on top of the 170 additional appointments that the CCG has commissioned until the end of the financial year will actually help us actually increase the number of face-to-face appointments that may be becoming available. Obviously, that's very much dependent on allowing a number of GPs as well as other staff being employed by those individual practices. So again, it's to do with the capacity issue is going to be quite key. So I think we'll see how that actually goes. But I think the key message here is what I'm picking up is that actually you are right. Obviously, lots of people do like to have that face-to-face appointment. But there are people out there that are actually, what we're picking up is saying they don't mind having the telephone appointments. Those tend to be the working age people because it's a lot easier to have a telephone appointment rather than travelling into a GP practice if it's a quick fire question as such. So I think it's a blended conversation here whereby you're going to have some individuals which are going to be very much that elderly, vulnerable groups, people with already pre-existing chronic conditions, or those people who need to be physically assessed because they're showing high level risk symptoms, because obviously we need to catch up and ensure that we're also identifying those people with cancer. So I think we're going to see obviously of a mixed version or mixed blended group as such, where you're going to be prioritising those people in those categories, and then for other people who could just be seen on the phone or video consultations or telephone consultations, they might want to prefer to do it that way. So I think it'll be a blended role. I don't think it's going to be, I think it's unfair to say everybody in Wokingham wants to see face to face, although obviously you might have a different opinion about that.
Yeah, thank you very much for that. Well, I just think I should come back on a couple of points. I think when you're trying to explain something to a doctor, I think when we've all kind of experienced it, sometimes it's easier to show what your ailment, what your particular problem is. Don't want to go into the particular, but it's a lot easier doing that as well. And there's also been a comment, and I think this is absolutely spot on, about body language. And they might think, oh, I'm all right, but you might look at their face or their mannerisms and think, this is not right. There is something else wrong. Can't put my finger on it, but you can't see that through over a phone call or sort of via the internet. So I still think, I mean, I'm going on the side of the patients here, absolutely, that the sooner we get back to what we had before, the better for all concerned. Because I think the doctors will get more out of their job as well, rather than doing endless phone calls. And that's motivating, I think, for them as well, to actually see patients and probably see them not very well, but the next time you see them, they're a lot better. So that makes them feel better. So I still think there is a heck of a lot more that can be done with this. I don't want to see it go on for years and years. I don't think it's always down to money. It's down to attitude of doctors and surgeries. Thank you.
Katie, do you want to respond to that?
Just on the final thing of the attitude of GPs, Wokingham GPs, I think actually generally the ones I work very, very closely with, and that's most of the GPs, the GP partners in Wokingham, their attitude is they prioritise their local patients, and actually they want to make sure that they have, ensuring that they have access, the highest access possible to the most vulnerable, the most needy at a time that is right for those individual patients. So the attitude of most general practices isn't, as you say, it's not about money at all. No, it's not about money for them. This is about how they can actually get the individual public to use the services appropriately. Just going back to what Amit had said here, for example, that person who was in his in their I think what did he say? It was actually a 20-year-old. This person had called for the ambulance service twice in 1 week for a urinary tract infection and a headache. That's a 20-year-old as such. This person doesn't have any pre-existing conditions, but this person is phoning up inappropriately. This, I would actually say, they might have been better to just phone up the GP. They might have, where they could have been followed up by a paramedic or a pharmacist, rather than phoning up the ambulance services. And unfortunately, what had happened is the ambulance service would have actually had to go and visit that individual 20-year-old and just give them support and advice. They would never have been scooped up, we'd say, in the actual NHS and brought to a ED department. It's just literally supportive advice about their own ongoing issues as such. So I think there's a wider piece here about making sure that the NHS as well as the council really support the communication about when it is appropriate to call 999. When is it appropriate to contact your GP? When is it appropriate to get advice from your local community pharmacy? So it's a mixture of things. You can't expect, we cannot go ahead and carry on expecting that everybody calls 999 or calls their GP practices. There's got to be much greater work of everybody, all residents, owning and understanding how they need to manage their own health needs going forward as such. Now, I'm saying that, But I'm also saying here that actually there are individuals, again, especially those people. So if this person's had a UTI and a headache and it's been repeated literally over the past couple of weeks, then that would have been appropriate because that might have been a flag. There might be something more serious going on. But from Amit's email, this has just been a one-off as such. So there's a way of organising the way that we're really supporting and making sure that we're training up or making sure everybody knows when it's appropriate to contact the actual health service going forward. But just to reiterate here, anybody can call 111 and get any advice that they need as such going forward, or call or look up information via NHS UK and get access to the information about what's actually they can be doing, and also where they get advice from community pharmacies.
Yeah, I agree totally with that comment about the inappropriate use of the ambulance, and I think the point should also be made that whilst that's happening, someone who really needs an ambulance can't have it because it's somewhere else, and there is a lot of education as well. And I think that you can also use much more of the chemists anyhow, and use them for maybe headaches and stuff like that. But if the headache's going on for weeks and weeks, then you've obviously got a little bit more problem than just probably an alcohol-induced sort of moment. But thank you anyhow.
Thank you, Michael. I think, Katie, we all very much want you to appreciate the size of the problem as the public sees it, because, you know, we all go out, knock on doors very regularly, invite people to give us feedback and tell us how they're feeling about local services, and their local GP practices is one of the first things they often mention. For example, in Woodley, people aren't very happy that the Loddon Vale practice, you now cannot wait inside. So when you go for your surgery appointment, if you're going to see a doctor, you have to stand outside in the cold and the rain, which doesn't seem at all appropriate to me, because hopefully people are only going to see the doctor because they're not well. Let me move on to, I know members have all got their hands up. So I'm going to go to Jackie, then Adrian, then over to Rachel.
Thank you. Actually, mine's sort of really crosses with Tanya than Michael's. I'm not 20, and I don't think inappropriate and call out anybody inappropriately, but you could call me vulnerable because I'm right at the other end, pretty old, and probably possibly needy. I live on my own. I have done for 30 years, so I have to look after myself and work out my own problems. And this is the same for a lot of the residents that I'm meeting, a lot of single people. So recently, 2.5 months it's taken for me to go to the doctor with a problem. And I mulled it over because of the pandemic and the queues and everything. So I got an initial appointment by walking in, and then after that, the doctor rang back 2 weeks later. That was the first time I spoke to a doctor. Then I got blood tests, then I got x-rays. And then 2.5 months later, tomorrow, I will hear from the doctor again. So not too good, really. Meanwhile, I've been worrying myself sick, thinking, what have I got? And really to go along with the others, when do you think residents will see concrete improvements with the surgeries?
Okay. Thank you, Julie. I'm so sorry to experience as such. It's not something that I would want for any of the actual residents in Wokingham. And obviously I will make sure that this is relayed back to the Wokingham GPs regarding those issues. It's a bit surprising to me that actually you have to wait 2 weeks for an actual telephone appointment.
Yep, I was surprised too.
Bit surprised about that. So I'm just wondering if one of these 4 individual practices that you belong to as such. But I will relay that back as such going forward, because this isn't the way that actually we want our local residents to be managed. It's something the CCG, as I'm from the CCG, I'm actually want this formally, because this isn't appropriate as such. To actually wait for 2.5 months before you actually have an actual response to your actual blood tests. I mean, it'd be fair to say, actually, if the blood tests were normal a polite thing to be said is actually they'll get the response, they'll do the bloods, and then normally within 48 hours the bloods come back, and if it's absolutely normal, it'd be polite to just go back to the individual patient and say everything is fine, everything is normal, possibly how are you feeling, what's happening now, we might need to look for something else as such. So it's just I think I need to dig in more into this, if anything, if this is okay.
Well, it is very patient led. I've had to make all the things, and this is happening to other people. They should be ringing in, or at least, and saying what the blood test is or what the X-ray says. Anyway, I'm waiting tomorrow.
Okay. I'm sorry that you've had that. It's something I'm going to take away and actually make sure.
Can I just make a point following what Jackie's just said, if you don't mind? It goes back to my point about developing a system that's based on customer need, i.e. your patient need, and not on the GP's perception of what the patient needs. And that does make a big difference in terms of what you deliver in the end. And I agree with you. And there are a number of examples. It's not a criticism as such. Don't get me wrong. It's not so much that, but everybody's working hard. They're investing a lot of money, and they want to provide a good service. But if you want to provide the right kind of service, you need, when you develop your systems or applications and stuff, you need patients on board to get a positive view and not get some of the outside body to say, yeah, this will work for the patient, because it won't. It won't be as efficient. Thank you. That's what I wanted to say.
Thank you, Damo. You are quite right. It's got to be patient-led in response to their individual services.
Okay, Jackie, did you want to come back on? Okay, thank you. Right, we're going over to Adrian.
Thank you, Chair. Firstly, Katie, thanks a lot for coming up to see us. We really appreciate your time and your contributions. I know it's not the easiest of conversations to have. Some of the questions can be quite challenging. I wanted to support Michael and Jackie with their comments around, can I say, more senior members of our society. I would like to also make a slight counterpoint, which is, in my working life, I spent 25 years on the road, and trying to get an appointment was basically impossible because I was in Wokingham Monday to Friday. And half the time, the last 10 years, I was somewhere in Europe. So when the surgery called me back and said, can you come back on Tuesday? I'd be like, yeah, well, but, I'm going to be in Frankfurt on Tuesday, so I can't make it. But I would also like to talk about my, other scenarios as well. Certainly my children and my wife have had, I would say, very good experiences with telephone consultations, which have accelerated some of the issues that my wife has had. So I think your comments about hybrid are some good comments, but back to Tahir's comment, it has to fit the patient rather than the other way around. I think that's what we're saying. I'm obviously going to talk about GP numbers. I'm just Googling research on GP numbers, and all the documents I can find on GP numbers look really quite negative. There may be some local initiatives, etc., that are being taken. What I would be quite interested in is actually the real number of GPs in the region and whether that's going up or down or not. One of the things we always need to consider, and this has been raised previously in this committee, is that we have built a lot of houses in this area, and with the government targets, we are likely to build a lot more houses. Previously, we were at Woking Medical Centre until that became completely overloaded and really struggled to function, I would have to say. I believe they went from I think when we joined, there was maybe 10,000 patients. I think there's 20 something thousand patients now, maybe more, 25,000. At some point, there has to be, in my view, an assessment as to whether the working medical centre or any individual unit can take that many patients, and whether it is appropriate to invest in a new surgery at another location or in the Wokingham area. And this is down to money, obviously. And one of the things I'd like to understand a little more is, as well as GP numbers, actual real GP numbers, is the amount of money that was spent last year, the amount of money that's going to be spent this year, the budget for next year and the year after, bearing in mind the population increase that we're going to have. You know, we are all hoping that there will be a significant investment so that we get back to where we were 5 years ago in terms of patient to GP ratios. But those are the things I would actually like to see in the reports, is some of the financial numbers and some of the head counts, if you like. Thank you.
Thanks, Adrian. So I'll take back your questions because I'm intrigued also to know what the actual real numbers of GPs are, along with nurses, admin staff, telephone staff. It'd be really good to get a picture of that, what the picture was pre-pandemic to what the picture is now, because I'd like to do a comparison of that. On the finances, I do know that actually we can possibly do a money consideration across the CCG of looking at what their individual income has come into general practice. So I'm happy to share that as well as a subsequent piece to Madeline and make sure this is covered off in your HOG meeting as part of the minutes going forward. But I'll look at the real numbers of the staffing and do a like comparison of the up and down. On the housing targets, the one thing I would actually say is we did a huge amount of work a couple of years ago now, looking at the growth that was put into the number of houses that were coming into Wokingham. The Wokingham Borough Council and also the CCG were working very, very closely with the individual practices to consider whether or not at the moment they were able to absorb the number of individual new residents that were expected as part of that housing growth. So at the time, we had done that assessment and actually all GP practices were able to absorb the actual an increase in the actual population size. The way that they had done that was by expanding in some of the GP practices the actual practice. So some of them had done extensions, and also some of them had brought in new staff which had been supported by the CCG. Now it's fair to say I think now you've also had another spurt of I think houses, so I think I'll speak with the primary care team for us to do another examination of the actual housing growth and the numbers that are projected to be going forward to see if other things have actually changed, and obviously looking at that from the point of view of also the pandemic as well, making sure that the staffing numbers are actually at the actual level that we had at pre-pandemic.
That's a brilliant answer. Thank you very much for confirming all those different points. Just one thing for your information, and this was a question that I believe was raised at the planning committee in Wokingham Borough Council rather than HOSC. And it was around provision of a site, because there was provision of a school in Montague Park, and there was also outlined provision for a GP practice in or near Montague Park, which was not followed through. And I think the response in the planning meeting was that the CCG didn't want to fund it or didn't want it or something like that. I'm not sure exactly what the final communication on that was, but just to let you know, subsequent to Montague Park, that the area south of the railway line is being developed as a strategic development location. And of course, it is possible. I've no idea on this at all, but it is possible that there would be future developments in or near those kind of locations, which would further, I would say, put the case towards a new GP surgery in that area. So just something for sort of long-term consideration.
Yeah.
But thank you so much for your answers.
That's fine. So I think time is probably now whereby I'll get my primary care team to work with your planners to understand fully what's potentially the new SEL site as such going forward. And I think actually the time would be to consider whether or not there is a need for putting in a new practice as it is at the moment. At the time for Montague Park, because I was actually Director of Operations in Wokingham at the time when this was actually looked at. The decision from the CCG there was the fact that we had actively engaged with the practices that are forming the boundaries of Montague Park and actually said, are you able to support those individual patients? And it was felt that actually they could definitely do that. It was, I think, lots of practices in the past. What was been happening is that we'd set up new practices which should be just covering a population of around about 2,000, but the local clinical evidence is saying to us nationally that actually you've got to have a fairly good size of a practice in order to make sure you have the high level of clinical competencies going forward. So based on the size of Montague, if we put in an individual practice there, it would have been a very small practice as such. So actually absorbing the work into the neighbouring practices was a better way of going forward. But now you've given me the news about the south of the railway, we might need to review our process again.
Thank you.
Obviously, we've got the local plan update come out, which we hope will be approved in 2022, and which is very good news for Wokingham Town in that they'll only be having 27 houses a year rather than the previous decades, 250 at least every year. Moving on to Rachel. Thank you.
Super, thanks very much. I think the kind of statistics and figures that you were talking about with Adrian, Katie, I think would be really, really useful. I've got a couple of things I was wanting to add into that, if that's okay. The first is, do we have any idea of the dimension added by the fact that presumably Wokingham has an ageing population, and it may be that actually, although you might have, say, the same number of people in a particular area, as they age, their need for medical appointments might increase, that sort of dimension. So that was the first question. The second was, I think, what's very often an issue for patients is surgeries will, for example, 8 o'clock in the morning, they will release a block of appointments. And you have to call up at 8 o'clock to get an appointment. Now, for a lot of people, that's the time they're trying to get to work. It's the time they're trying to get the kids to school. And I'm wondering if you have any statistics at CCG level of the amount of time for each surgery patients have to wait to get an appointment, literally waiting on the telephone, the number of calls which are abandoned, and even potentially the number of patients who end up having to go elsewhere. So, for example, to go private so that they can get an appointment. It would be really interesting to understand that dimension as well.
Yeah, thank you, Rachel. So on the point of view of the actual ageing population, the one thing that the public health colleagues and myself have done in the past is look at the population growth in Wokingham. We do know that actually, yes, we have got an actual ageing population, but we've got more of a growth in the working age population, more people coming in to the area who are actually between the ages of sort of 35 and 50 as such, as opposed from the frail. That seems to be the biggest growth as such going forward. However, we do know that actually the number of people who are now living with a lifelong condition is growing. So the number of people that actually have multiple long-term conditions such as diabetes, respiratory disease or cardiovascular disease is increasing. And you don't have to be elderly for that, but you would be deemed to be frail because lots of those individuals do have a very complex medical and social care needs going forward. And we are seeing an increase in those types of conditions as such. So again, these are the key things that we need to be advising the local residents about public health messages in order to prevent people from getting those lifelong conditions going forward. So I wouldn't necessarily say it's about the frailty as such. I think it's more to do with, well, not only to do with the elderly population, it's more to do with that frailty type of population that we need to be targeting. On the point of view of the actual data on the waiting times, the CCG had in the past done a mystery shopper approach of calling up and waiting and listening to how long individual practices had responded to respond. It was variable, and I think this is where it comes back to my presentation. The one thing that we're looking to do here is actually standardise the messages and the processes on that telephone system. So if we're able to standardise this, then we'll be able to better monitor it. At the moment, most GP practices use either a different telephone operator, they have different waiting times, they have different messages. So it's quite hard for us as a CCG to do that information that you had asked for about the embezzlement rate, the actual waiting times, because we've got nothing to compare like for like for going forward. Hence the reason why the CCG, what we're aiming to do here is actually try and get all the practices to standardise their approach to telephone messaging going forward. Once we've got that agreed and supported, it'd be a lot easier then to report on what you'd asked for, Rachel.
Super, thank you very much.
Give you a question, Kate, and Katie, thank you very much for the time you've given us this evening. Certainly agree with Adrian that we ask challenging questions, but I'm afraid that's our job. We are here to represent our residents. We're not the voice of the council, we're the voice of our residents here at the council. And you know, we are hearing so many people that aren't happy, which is why we've shared that with you this evening. Don't worry, Katie, we know you're not personally responsible for everything, but unfortunately, you know, you've been the figurehead for it all tonight. So we really appreciate you giving us this time, and we look forward to seeing you again, seeing some of the results coming back. As you said, there's a lot happening just in the next couple of weeks, because we really look forward to seeing some concrete improvements in particular those 4 practices.
Yeah.
I have to say I'm a patient at Notting Vale myself, and my own experience has been very good. So, you know, perhaps we hear a lot from people who aren't happy, but unfortunately there are a lot of them. So members, I think everybody's had the opportunity to ask Katie questions. So thank you very much.
I'm going to go now. Kiss my
Right.
Thank you.
Thank you.
Thanks, Katie.
Okay, next item on our agenda is Health Watch. And I know how much we value the very, very thorough work that Health Watch do, speaking to residents, patients from across the borough. And this report, which has reached out to listen and give us all the stories from carers and their experience of, well, particularly the lockdown, but, you know, during the COVID, seeing all the quotes and, you know, the direct experiences, it really opened my eyes to how it feels, because this is ongoing, isn't it? And I think members will have a lot of questions, and we certainly appreciate the work that you're doing. Would you like to speak and then take some questions? Thank you, Nick.
Yeah, good evening, everyone. You'll forgive me, I've got a bit of laryngitis, and 15 minutes before we started, I heard of the death of a close family member. So I hope you can hear me, and I hope to stay present and make some sense of what I'm saying. I did put a summary together, summary presentation, but it's quite difficult to do it succinctly with that much information. So I can either take questions or I can present it, whichever you prefer.
Nick, we certainly don't want to take any more of your time than's necessary this evening, and please accept the sympathy of everybody here tonight. Members, can we move to some questions on this report? Bear with us, Nick. Were you pleased with the level of response that you received for this?
Yeah, well, it's always nice to get more responses, isn't it? But we were hoping to get about 100 responses, which is what we got. I think that was quite a good response. We were particularly happy to have the 3 focus groups, because that brought an extra flavour to it, to have those people, albeit on Zoom or MS Teams, to hear from those people directly. And, you know, particularly some of them were quite upset, just from their, not talking about service providers or anything, just about the situation they found themselves in. And there were some really interesting quotes. I'm not sure we put it in there, but one that sticks in my mind is some carers were talking about the first lockdown. When everyone had to go into lockdown, they said that wasn't too bad a period for them, because they're used to being stuck at home, and their thought was, welcome to my world. That was their quote, not mine. Welcome to our world. We can't pop out for a coffee and do those sorts of things. When they found it really tough is when the lockdown was released. They were still there because they might have someone who's shielding, and everyone was going back off doing what they would normally do, shopping, going for a coffee, that sort of thing. So it's quite compelling, really, to sit and listen to that stuff.
Yeah, I think the focus groups are very, very valuable, because they're going to enable people to bring up issues that the questions might not have covered, because, you know, it's impossible to try and get a survey to cover everything, but because there's so many different situations. It was interesting that you had people who perhaps hadn't recognised before that that's what they were. And I mean, I was quite shocked that 40% weren't registered as a carer with their GP. I hope they all now are, because you've been able to explain to them the advantage of doing that. But that was quite shocking that was so high.
But that was a key one of the recommendations, is what do we do collaboratively, because that's the best way to do it, through the council, through the CCG, through the voluntary and community sector, to highlight carers' rights, the benefits of registering with the council and carrying out an assessment, the benefits of registering with your GP practice.
Thank you. We've got a question from Tahir.
Thank you. Yeah, it's really scary reading this. I was just wondering, we adopt children, and one of the things that network has, it's a network where people who do adopt children basically can talk to each other, and if they've got similar issues, they can just run those past each other. Occasionally, we meet up for coffees or on Teams, or just as a social thing. Is there anything like that for the carers? Has anybody set anything like that up? So that, I mean, the mental health impact at 84% is just frightening, really. And really, if you had people who you felt supported you, or somebody just to talk to, that would make such a world of difference to them.
Yeah, well, there's carers groups in Woking Borough Council, and they of course existed before COVID, but they couldn't operate in exactly the same way, as we all know. So pre-COVID, I would meet with carers groups either at coffee morning or in the meeting room at the fire station, because it's free of charge, and that was their way of getting together and talking about the things that they were going through. But those did carry on, that's my understanding. Well, in fact, I know they did. They carried on in a digital way, But of course, as we know, that excluded some people because not everyone is digitally enabled. I do know since the restrictions have been lifted, those groups are meeting up again. I've spoken to them. I've seen how much they value having those groups getting back together again. So you would have Tuvida, who the carers group, who run different sorts of carers groups. You have places like the Link Visiting Scheme that have been meeting up again. So that addresses some of the isolation issues that were going on. You have the Young Carers group with the opportunity for them to meet up. But I think it's referenced in the report. You know, they were all zoomed out. They were doing Zoom for school, Zoom for their young carers meetings. They just wanted to get together with their peers.
Thank you.
I think it's worth acknowledging, actually. It's worth acknowledging the good stuff, and that is in there. And I tried to pull it. It's maybe in pieces in the report, and in the presentation, I tried to pull it together in a slide about the good things that happen. So the comments about the WBC community response, the one front door, all of the other VCS groups who were brilliant in contacting carers. So there was a lot of good stuff that went on too.
Thank you. It's good to hear that.
Okay, Sam.
Thank you, Chair. Nick, my question was just more of a comment really. Just well done on page 33 on the summary. It says carers found it easier to get food and medication during the lockdown than carers in other areas, thanks to Wokingham's community response. Really great to hear. Just wanted to, if you could explain a bit more about how this was done and how we managed to be better than other areas in this way.
Well, I can only give the feedback that they gave us. So when they were giving those comments, it was through the WBC community response, so through one front door particularly. But there were other organisations who were providing those services. They were cropping up everywhere, you know, where I live, and I know that happened also in Wokingham. I live in Yateley, but the local churches put together a community response team who would go and help local residents get those things.
Brilliant. Thanks, Nick. That's really great to hear.
Thanks, Sam. I'm going to go to Adrian next.
Nick, thanks very much. Yeah, a very thorough report, I would say. You know, bringing together factual information, statistics, also references from the King's Fund, etc. I think in previous meetings, I've always said you provide some great stuff. Now talk about the actions that we need to take. And you've started to list out some actions, and the action plans look really good. You know, but as I'm always told by my wife, there's always something more to do. So what we need to do clearly with these, I would say cross organisation, cross NGO action plans is start to bring together agreement around these and flesh those out a little bit. But this is a very good starting point for these action plans. I really like them. It's not just obvious things. It's trying to improve, you know, who knows about things, how we should start identifying all the missing people. We all know there's lots of missing people, and this is trying to address this. Getting the CCG on board to assist here as well, I think is a really good idea. I like all of this. I think we just need to continue down the road a bit and get agreement with all these bodies to flesh these action plans out. But yeah, it's a really good report and really gives us facts that back up, I would say, what we thought already. I mean, I think Tahir said it's scary out there. I think there are some good points, and we talked about those, and you know, fantastic responses from Wokingham locally, the churches, etc., which is fantastic, brilliant. But there is still a massive underlying need, which we need to I would say in the first instance, expose, and then start to make sure that everybody can utilise what they can utilise and get as much as they can from all these different organisations who actually want to help most of the time. But yeah, really good. Thank you very much.
Yeah, and I would agree with you. That's why in the recommendations we've included we all want to work in an integrative, collaborative way, don't we? And we've seen how beneficial that can be over the last 18 months. So it's not a job for one person, not just a job for Woking Borough Council or for the CCG. That's why I've referenced the voluntary and community sector in there. You know, so we know that the CAB have started their mobile advice van. So I think they're going out next week and the week after. So it's the first of the programme. We can only join them on a couple of those because we've got things like the tendering for new contracts and moving into the voluntary and community sector hub, but going forward. So I would see that as a platform for Healthwatch to promote to people who might be carers that are hidden. So we've got lots of opportunities. And I agree, there was so much great work done, but you can always do more, can't you? You can always do more if you want to.
Yeah, I'm moving a little bit to the negative side. I wanted to drill down a little bit on the direct payment stuff, which looks like you've had some bad situations. Do you want to give some evidences or?
Yeah, well, there's quotes in there. You know, we'd always follow up a statement with a quote because it's not our opinions. They're the experience of the people we spoke to. I think the way I'd summarise it is that the type of money they would have spent their direct payments on disappeared. They couldn't no longer have a personal assistant come along and help their 18-year-old autistic adult because you weren't allowed to get together. And some people were proposing spending that money in a different way. Some people were successful, others weren't. So it's hard to really drill down, and the council probably might be able to give more clarity around that and will probably respond. So I think it's what we found in some other areas is that those who challenge enough are the ones who will find their way through the system and perhaps get what they want, and those who can't do that maybe don't. Or it might be an issue of the person they were speaking to having a different understanding of what those payments were allowed for. So I think, you know, we've done the recommendations. We've asked the CCG for their response. I've asked for a response by today, not had one yet, but I'll chase them because I know they're busy. I totally accept that. You know, there's lots going on at the moment. And of course, Woking Borough Council can respond too.
Yeah, I don't know whether we need to take that as an action for Matt Pope or something, or maybe Madeline could advise on that.
Well, I mean, we, as a committee, we make recommendations, and perhaps a member would like to put forward a motion that we're supporting the recommendations within this Healthwatch report. I think adult services have been received this in that it was a draft version. I know, and I hope they'll be taking this on board, but certainly that's a recommendation that we could make. Rachel.
I was just going to first of all say thank you very much for this.
Oh, sorry, Rachel. I thought you were commenting on what I was saying.
Yes, I am.
Oh, right. Sorry, yeah. I thought you were going into your question. Okay, go on. Go ahead.
I was just going to say thank you very much for the information in this report, which gives us things to work on. And then I was going to say to the chair, it looks as if there are actions in here for bodies in the council, bodies outside of the council. Would it be owned by somebody like Matt Pope to pull together all of those different strands to make sure that the council is addressing it and working on all of these different strands which are given in the recommendations?
Do you want to put that into a motion? Have you got the wording of it?
I guess it would be that we can we assign somebody?
No, we can only make a recommendation. Yeah, we can't direct anything to happen.
Can we recommend that as a result of this report, somebody within the council is assigned to take ownership of the various actions within the report and to drive them forward to a conclusion.
Well, perhaps we could recommend that
Yeah.
the lead member. I don't. You can't put somebody.
Yeah. Shall we get, Adrian and I just had a slight side conversation here.
Okay.
Shall we get back to you on that?
I think so. I mean, Nick's probably aware, and hopefully all the members are, that WBC is sending out on behalf of the NHS. There's a national survey to carers, so that a random sample of carers in the borough have had that in the post. They've probably got it now. They're being asked to send it back in November. But I mean, in the article I've read, as we've all been surprised to learn, there's a huge disparity in the number of carers known to the Borough Council. It quotes more than 700, and yet, as we'll see at the very end of the recommendations, 3,644 carers registered at the surgeries, which is, by quick reckoning, about 20%, I think, Nick.
Yeah.
So having been shocked at the 40% of the people who replied to the surgery, thinking about that. So yes, certainly we want to recommend that the NHS, if I suppose there could be some GDPR issue there though, shares, the numbers of the information about the carers that they know with the Borough Council, so that the council are giving direct support and recognising them, because the survey that's gone out, a random sample of those 700, would probably be less people than you were able to contact, would it, Nick?
Well, I wouldn't be able to contact those registered with GP practices.
But your survey was sort of very widely advertised as being accessible to anybody who was a carer and wanted to take part.
Okay. Yes. Yeah.
So coming back to Rachel.
Yes, because I do feel that what we've got in here, if you're looking at pages kind of 18, 19 on this report, we're going into a number of really good, really actionable things that the council could do, either itself or to coordinate with the other bodies that we deal with, that we could start acting on these as a council. We could start acting on the points which you've raised really quite quickly.
I would say, and it's at the top of the recommendations, that it took us some time to put this together. But of course, at the same time, there was the Berkshire West Joint and Health and Wellbeing Strategy underway, which we were involved in and ran some focus groups, and it was drilled down to 5 priorities, and from that we now have the Wellbeing Board strategy into action. So there are already some projects and work streams underway that would cover some of this off, or some of these recommendations could be pulled into there. So for instance, a carers action group could perhaps pull some of these recommendations into there and then decide how we're going to make progress on those. For example, the collaboration between the voluntary and community sector and the council and the CCG to find those hidden carers. There's also the ones in the strategy into action around mental health. There's also the one around isolation, which was highlighted as part of this. So some of those things are underway.
That's good to know. Thank you.
Right. We do have in the meeting with us tonight the Deputy Executive Member for Adult Services. So perhaps we could just directly ask Phil if he'd like to tell us, whether the borough will be able to take on some of these recommendations.
Yes, good evening, everybody. I hope you can hear me okay. Yeah, what Nick has said is quite right. There are some of these actions and recommendations which are covered in some of the work that's being done underneath the structure of the Health and Wellbeing Board. And there are further conversations which we are having with our team on how we will respond to this, but obviously it's not my place at this moment in time to give a direct immediate response to the recommendations on the report, except to say that from what I've read, they all read as something that I would like to be supporting.
Thank you very much, Phil. Adrian.
Yeah, this is really to Phil. Thanks a lot for those comments, Phil. I think it's impossible to give us an answer right now. That wasn't the purpose, really. Certainly not from my side. Instant responses are normally wrong, but it's very pleasing to hear that you're broadly in support with these, I would say, what look like very, very sensible suggestions. And hopefully we can move some of these along with the Health and Wellbeing Board, et cetera, et cetera. But thanks a lot, Phil.
Right, so I think what we could do is, as chairman, I will write to the lead member, strongly stressing our support for these recommendations, and asking that at the next meeting of this committee in January, we have an update on the progress Woking and Barrow Council has made with what their role is within the recommendations. Would members be in support of that? Okay, can I see a show of hands? Thank you very much. Right, Nick, once again, thank you so much for everything you do at Health Watch, and please pass back to all of the carers. We know that, well, we know there's thousands of people out there doing an invaluable, very stressful, very difficult job, and the fact that you've been able to give them a voice and listen and present that, and hopefully we can see some changes, is very, very much appreciated.
Yeah.
And I hope your laryngitis clears up, and it's very, very good of you to come on the call despite the sad news you've received, and we'll let you get away from us now. Thank you.
I've got a couple of comments I'd like to make because I think they're relevant, actually, or the councillors might like to hear it. So one was today, my colleague and Joanna moved into the VCS hub, so two of the first two organisations to do that. So that's us and Mind, and I think that's a really positive day for Woking and Borough, that place is now ready and organisations can now move in and collaborate together. So we should be working from there from now on rather than from home. So that's a blessing in itself. And the other thing is, with some other Health Watch across the South East, this is relating to the GP access. Of course, we'd heard about GP access and we know the issues, but we have to do something because that's the way we operate. You know, we take action based on what we're hearing. We're hearing so much about it. But what we've decided to do is, rather than go and do a survey with patients, because we know what they're going to say, we put together a steering group that included not only the Health Watch team, but a GP practice manager, a doctor on the LMC, the CQC, who developed this survey for the staff of GP practices, because we really wanted to understand what it's been like for them, because they've seen huge change in the way they work too, and we thought that might help us develop the survey that then goes on to the local patients. So I just wanted to let the councillors know that that's a piece of work that's ongoing now.
Thank you very much. Right. Okay, members, we're moving to looking at the forward plan. Anybody got any comments on what we're looking at in January?
You've heard today with some of the
presentations, they've offered to come back in the future with the CCG and also RBH. I would suggest members may wish to have an additional meeting because it seemed that a lot of the suggestions were that they come back in January, which is already looking quite full. So my suggestion would be to members that you may wish to have an additional meeting, potentially say RBH and maternity together. As,
to have a meeting, well, we've got a meeting on the 19th of January and then the 16th of March. So to have a meeting in middle of February. Looking for general agreement here, but yeah, okay, let's look for a date when the council calendar allows that. But I think that might be in half term, and the council calendar tends to be clear in half terms. Yeah, we have got quite a lot on. Are we assured that the public toilet provision report's going to be ready in January?
Have they got something to go on?
Well, if you remember, I think we were expecting that in October, no, September.
Yeah, I've made the request, so it's being followed up, and we have had confirmation of the continent service, certainly for January.
Yeah, because the two items would go together. All right. Okay, it's just that looking at we've unscheduled topics. We've got the autism strategy that I know we were quite keen to have a look at, and also the 2022 update on ICS and the implications for the borough. Which items were you proposing for the February extra meeting?
I was proposing maternity services and the further update from RBH.
Yeah, so perhaps we could look at the autism strategy then. Is it likely we will have an update on ICS by then?
I will ask the question.
Oh, okay, we'll find out. Right. Members, is there anything else anybody wants to raise about the activities of this committee? No, in that case, I'll thank you very much. I hope you enjoyed joining HOSC, Rachel.
Yes, thank you very much. It's good to be back.
And I'll see you all in the new year. Thank you.
Thank you.
And I'll close the meeting.